Thank you very much. My name's David Jane. I work in Cambridge in the United Kingdom, where I'm a professor in the Department of Medicine. And this section of today is going to focus on the complications and comorbidities of EGPA. As you've heard in the earlier presentations, EGPA is a multisystem disorder that can affect many different parts of the body. What's important to appreciate is that EGPA can cause inflammation, which can be reversible, permitting full recovery of the tissue, or the inflammation, certainly if it persists, can result in damage, which means irreversible changes and often a loss of function in the tissue that's affected. And over time, patients will accrue more irreversible change as a result of repeated episodes of inflammation driven by the EGPA, but also as a result of other disease events, such as cardiovascular disease, which are common in EGPA patients. So this slide just summarizes some of the major complications in different organ systems. As we know, asthma is a key feature, but in the lung, longer term changes can be interstitial changes, bronchial wall thickening, bronchiectasis, and other changes. Cardiovascular involvement is more common in those with higher eosinophil counts, particularly a myocarditis, which can result in cardiomyopathy and arrhythmias and heart failure. Renal involvement occurs in around 15% and typically presents with a crescentic nephritis with a rapidly progressive glomerulonephritis on biopsy that can produce chronic kidney disease, rarely leading to end-stage kidney disease. We know gastrointestinal tract involvement can occur anywhere in the gastrointestinal tract. Biopsies will show an eosinophilic infiltrate, and you can see ulceration or inflammation of the intestinal lining. There are several cutaneous manifestations, such as purpura. You can get painful subcutaneous nodules, erythema nodosum. When the peripheral nervous system involved, this is a vasculitic polyneuropathy, typically with a mixed sensory and motor component. And there are almost always permanent consequences, although you can often get a degree of recovery. Patients are often left with either some painful neuropathic features or some sensory deficits. And then we see ear, nose, and throat manifestations. The chronic ear involvement, such as otitis media, can result in deafness. The eighth cranial nerve can also be affected, or the inner ear, resulting in sensorineural hearing loss, which is usually irreversible. The loss of smell can come and go, but can be permanent, as can changes in the sinuses and nasal obstruction as a result of polyps. And then joint involvement is less common in EGPA compared to other vasculitides. So asthma and rhinitis really dominate the longer term disease course of EGPA and are typically the drivers for the high steroid exposure that these patients require to control these symptoms. Asthma is really present by definition in all patients at diagnosis with EGPA, but longer term asthma occurs in up to 50% of patients and is often associated with evidence of eosinophil activation. The rhinitis and sinusitis often parallels the asthma. It's controlled with higher doses of steroids. As the steroids reduce, so the ear, nose, and throat manifestations recur, particularly with nasal obstruction due to polyposis, which is really an overgrowth of the nasal epithelium. And then the rhinitis, which produces a clear discharge, and sinusitis, which can be painful. So there have been efforts to subgroup EGPA, and these have typically used the ANCA biomarker, ANCA being an autoantibody present in 40% of EGPA patients, and have looked for the difference in organ manifestations in the frequency of organ involvement for different organ systems. And this slide summarizes the frequency in the ANCA negative group on the left and the ANCA positive group on the right. And as you can see, it is usually myeloperoxidase ANCA that is the ANCA subtype detected in EGPA. And indeed, recent genomic studies have demonstrated that genetic predisposition of patients with EGPA follows the same phenotypic separation, namely the MPO ANCA versus ANCA negative have different genetic susceptibility. And this shows that in nose and throat involvements present in 80% plus, neuropathy, quite common, but more frequent in the ANCA positive group. Note that cardiomyopathy is the reverse, because the ANCA negative group tends to run higher eosinophil counts and tends to have more frequent cardiac involvement. Renal disease, glomerulonephritis, goes along a little bit with the neuropathy, so it's much more common in the ANCA group. And this sort of codes with what we understand about the pathogenic potential of the MPO-ANCA antibodies, which have been shown in animal models to be able to replicate the glomerulonephritis. What is important is that the accrual of damage in vital organs is the most important contributor to the long-term health of EGPA patients and indeed their long-term survival. So cardiac insufficiency and older age patients have been associated with a poor prognosis. Paradoxically, ear, nose, and throat involvement, which doesn't kill you but just can make life miserable, has been associated with improved survival. And the positive MPO ANCA status, so that is the ANCA subgroup of EGPA, has been associated with an increased risk, certainly for vasculitic relapse.
David, thank you very much indeed. I was thinking, as a clinician, are there patients with EGPA who run a more benign course than others, or do all have the potential for very serious disease?
No, I think that's a very good point. This is a heterogeneous disease, both in its severity and in its disease course. But I think what we can say is that if you are going to have severe vital organ involvement, and here I'm talking outside the lung, I'm talking about the heart, brain, kidneys, it's usually present at presentation and in fact, it's usually part of the reason why the diagnosis is made. So there is a big variation in severity. And as you know, the French group for a number of years have recommended different types of treatment for those whose disease is more life-threatening to those in whom it's not life-threatening.
And so, thinking about life-threatening disease mortality, is it the cardiac involvement that underlies that, or is it more common in those with the renal involvement? Is there a clinical pattern that one can focus on?
I think you're right. I think the cardiac involvement is the most frequent negative prognostic factor that patients have. But the French developed a score, so-called 5-factor score, which was based on features present either in the brain, the heart, the gut, or the kidneys. And basically, if there was clear involvement in those organ systems or in manifestations in those organs, that adversely affected survival. But in terms of numbers, the renal involvement is less common, gut involvement is less common, central nervous system involvement is less common, but the cardiac involvement, I think, is the most common severe manifestation that we see. And of course, this places a big priority on making an early diagnosis and trying to diagnose patients sort of in the inflammatory phase of their disease before they've suffered irreversible damage. And we heard earlier about the long prodrome that these patients often have before the diagnosis of EGPA is made.
Yes, so it'd be helpful to understand, in terms of monitoring these patients, what is your approach in terms of monitoring cardiac potential?
So I think all EGPA patients should be considered at risk of cardiac disease and worked up accordingly. And the package that we would normally do is to ask the patient about cardiac symptoms, such as palpitations or chest pain, breathlessness. We would check troponin and BNP from the blood, and we would do an echocardiogram. There is a debate as to whether all patients with EGPA should have a cardiac MRI. But in a study we published a couple of years ago, we demonstrated that screening with the list of items I just mentioned is really adequate, and that if the echo and the blood tests and the history is completely benign, cardiac MRI is unlikely to influence the patient's long-term course. You may detect some mild involvement on cardiac MRI, but the cardiac function is usually normal. So we would reserve cardiac MRI for those patients in whom there was abnormality in one of the other features.
Right, thank you. I was unaware that ENT involvement gave you a better prognosis. Is there any insight or understanding for that?
To be honest, I think this is actually a misinterpretation of the data, because what happened was the French, who published their 5-factor score, updated the 5-factor score with factors that were good prognosis factors. But in this analysis, they used GPA patients as well as EGPA patients. And I think the prognostic benefit of nasal involvement or ENT involvement came from the GPA, not the EGPA patients. So I think that probably is not that appropriate to EGPA.
Oh, thank you very much indeed. It's still a lot for us to learn. Thank you.